12-fold increase in vaccine deliveries compared with the first half of the month. Nearly 12 million doses were delivered through COVAX to 24 countries in July. This is more than the volume received in April, May, and June combined, and bringing the total number of doses shipped to Africa so far to 91 million. We need to be clear though, in a continent of over 1.3 billion people, this is just a tiny drop in a very large ocean. And in the face of a surging third wave and more contagious variants, vaccine shortages leave Africa dangerously exposed. We have a very long way to go. With less than 2% of Africans fully vaccinated, we cannot get vaccines fast enough into the arms of the people. However, the efforts to scale up shipments are paying off. The current dose sharing by the United States government and European countries are expected to continue, and shipments from the United Kingdom will start soon. Countries will also be receiving new rounds of COVAX allocations in the coming weeks. Until the end of September, we expect around 110 million doses to be delivered to African countries through COVAX and the African Union. We do indeed commend the African Union's efforts and the message that we received this morning of the doses that they have secured to increase the number of people vaccinated on the African continent. Beyond September, as commitments by COVAX and the African Union and bilateral deals come through, we hope to meet the target of vaccinating 30% of Africans by the end of this year. But we also need up to 250 million more doses to complement the COVAX and African Union doses to meet this goal. In this new phase of COVID vaccine delivery, many countries will receive more than one type of vaccine, batches with varying shelf life, as well as single and double dose vaccines, meaning that logistics of vaccine rollout will be more complex. It is important that countries set up vaccination strategies that will ensure doses are efficiently administered. At WHO, we are supporting governments to implement measures that will maximize the impact of COVID-19 vaccination, including simplifying the rollout at local levels, as well as minimizing wastage. We continue to work with countries to ensure that key aspects such as assessing their vaccination coverage, usage capacity, COVID-19 infection rates, as well as vaccine management are well anchored to successfully vaccinate their populations. As the vaccine pipeline grows, countries may see a surge in demand by the population. It is also possible that the demand could be low despite availability. As such, countries need to monitor and adjust their rollout strategies accordingly. Importantly, vaccine rollout plans should aim for a high uptake in priority population groups and provide equitable access for all populations to achieve high vaccination coverage. Africa is no stranger to mass vaccination campaigns. Although COVID-19 vaccination is an unprecedented drive that presents many challenges, the continent cannot continue lagging behind the rest of the world, to share the endeavor to save lives. I thank you once again for joining us, and we look forward to a discussion.
Thank you, Dr. Fiona. And now to you, Mrs. Joanna Admiro. Angola has received different types of COVID-19 vaccines. Can you tell us how your country is prioritizing and managing the rollout of these vaccines?
Bom dia a todos. Eu estou a ser ouvida?
Go ahead.
Estou a ser ouvida? Bom dia. Eu queria fazer uma introdução sobre a situação atual no país. A situação é estável, pese embora com o registro de infecções elevadas em algumas províncias do país, em particular nas províncias do Huambo, Cunene e Huila. A capital do país, que era o epicentro da pandemia, hoje tem uma situação mais controlada. Em termos gerais, o país tem confirmado 43.158 casos, dos quais 2.550 ativos. Destes, 158 casos foram confirmados nas últimas 24 horas. Até agora o país registrou 1.026 óbitos, com uma taxa de letalidade de 2,4 e de 5,9 para casos ativos. No total foram recuperados 39.582 pessoas, sendo 193 nas últimas 24 horas. O processo de vacinação em Angola como vocês sabem, isso já foi dito, Angola recebeu nas primeiras doses da AstraZeneca, isso no mês de março, 2 de março, 624 mil doses da vacina AstraZeneca, através do mecanismo da COVAX. O país também começou no mesmo dia a vacinar os profissionais de saúde da linha da frente. Até a data foram administradas um total de 970.607 primeiras doses e 716.979 segundas doses, fazendo um total então de 1.687.676 doses administradas, correspondente a 94% de utilização da vacina já recebida. Para a campanha de vacinação foram mobilizadas para cada povoado que nós consideramos que é o posto de vacinação de alto rendimento, uma média de 300 pessoas, e entre técnicos do Ministério da Saúde, órgãos de defesa e segurança e instituições parceiras, também temos a OMS, Unicef e outros ministérios. Portanto, para além dessas vacinas, a vacina da Sputnik, a Pfizer, a Sinopharm e para além da AstraZeneca, até o momento nós recebemos aproximadamente 1.836.000 doses de vacinas, 660, e nós temos já coberto aproximadamente 5,7% da população alvo. E também temos como desafios a crescente a demanda pela vacina, a escassez de vacinas, que poderá também, a incerteza em relação à data da chegada das próximas vacinas da COVAX, a tendência a expandir a estratégia de vacinação às outras províncias do país, atingirmos os municípios mais distantes e as populações nómadas, tendo em conta o alto nível de transumância humana no país, garantir vacinas, materiais e insumos para a continuidade da vacinação, descarte de material por furo, portanto, e lixo hospitalar, estabelecer acordos transfronteiriços com as 10 províncias que fazem fronteira, então, com os países da RDC, Zâmbia, Namíbia, e de forma a garantir uma vacinação conjunta. Essa é a introdução que eu queria fazer antes, sobre a situação de Angola.
Obrigada, Ms. Joanna. Thank you very much. So now that you have heard from all our panelists, it is time to ask your questions. You can do this by using the Q&A function on the Zoom platform. And if you would like to go live, please indicate that by raising your hand. And remember to give us your name and the name of the media organization you represent. We have on hand Dr. Gilson Pala, who is a routine immunization and new vaccine introduction officer at the WHO Regional Office for Africa, and Dr. Fiona Braka, who is the program manager for emergency response here again at the regional office. They are on hand to answer your questions. So right now is your time to ask your question. Rhoda, are you ready to ask your question? See.
Hello, it's Paul Adepoju, and my mic is on, so I think I should.
Okay, we can take you first, Paul.
Yeah, so thank you very much. Today we heard a lot about Africa's the new Johnson & Johnson vaccine. So I would like to know what is being done by WHO, whether WHO is involved in any way in helping countries to quickly roll out these new sets of vaccines that they will be getting, and whether these plans are adequate enough now for Africa to get to its desired coverage. And I also have a question. I don't know whether the sequencing expert is on ground. We found out that the data from Africa, sequencing being done in African countries, are really like getting too late, like several weeks behind, and we are not having a true picture of what is happening in real time. I don't know whether this is correct and what is being done to actually improve the turnaround time of Africa's sequencing capacity. And my last question is on Nigeria's third wave. Nigeria is a very big country, and it has been confirmed that the country is in a third wave now. So with its population size, what do you think Nigerian government can still do to quickly stem the spread of this pandemic? Thank you very much.
Thank you, Paul. The first part of the question, Dr. Fiona Aterube, if you can answer that, and then Dr. Fiona Braka to answer the second part of the question.
Thank you very much, Mary, and thank you, Paul, for that excellent question. Indeed, like I mentioned, we welcome the African Union's announcement this morning. We as WHO are a technical lead in this work in rolling out the COVID-19 vaccine on the continent. Our work actually does embrace all vaccines, irrespective of where they come from, irrespective of the source. So indeed, we supported countries to develop their national deployment and vaccination plans, which plans encompass all vaccines, again, irrespective of the type of vaccines. We do support countries in the planning and preparation for the vaccine rollout, in risk communication, in registering each vaccine and regulation of the vaccine in each country, and also in safety surveillance. It doesn't matter what vaccine it is, we support countries to ensure that they are ready to roll out whatever vaccine it is. So we were aware that these doses were coming. We're working very closely actually with the African Union and Africa CDC to plan for this rollout in countries. We're aware the vaccine doses were coming. Since we're working closely in contact with them, we knew that they were actually coming in August. We expected them end of July. We knew they were coming around this period of time. This is the time that we expect multiple products coming onto the continent. Most countries did not have Johnson & Johnson, but right now we've also put out a guidance and are supporting countries to be able to roll out these multiple products, including the Johnson & Johnson, which is the only single dose vaccine that we have so far approved for WHO emergency use listing. So indeed, we are supporting the countries irrespective of the source of vaccine.
Thank you, Dr. Aterube. Dr. Braka?
Thank you for the question on the efforts to improve on the genetic sequencing turnaround. I would like to inform that WHO, along with the Africa CDC, did start an initiative last year to try and support the region, the countries, in improving genetic sequencing capacities and genetic surveillance. And to date, 53 countries have so far submitted their information or benefited from this initiative, with over 31,000 samples that have been sequenced. So we are seeing over time improvement in the genetic sequencing capacities. As WHO, we are working with countries to improve their own capacities, those that have genetic sequencing capacities. And we do this through trainings. and support for supplies to enable them to conduct these activities. We are also working in the Southern African region. We do have a lab set up there, working with partners and the South African government to support 16 countries in the Southern African region. And our plan is to scale this up to the western part of Africa and central part of Africa. So a lot is going on currently to improve the capacities in country and also subsequently improve the turnaround time for results.
Thank you, Dr. Braka. There was a question on what Nigeria can do to improve their response on the third wave.
Yes, we are seeing a resurgence of cases in about 16 countries in Western Africa, including Nigeria. Over the past 7 weeks, we have seen an increase week on week in the number of cases in these countries and an exponential increase in the last 3 weeks. So Nigeria, in addition to other countries in the bloc, are experiencing a resurgence. And really, the main drivers behind this are the spread of the Delta variant, which is highly transmissible, but also public health fatigue in meeting up with the public health measures that are recommended. Our advice to the country and other countries is that as much as possible, we have to continue the effort to improve on public health measures implementation as we look at scaling up vaccine uptake. But in addition to that, also working on improving the capacities to manage critically ill patients with COVID, so stocking up on supplies for treatment of critically ill patients, and also oxygen production and availability so that we are able to reduce the mortality for those that do contract COVID-19.
Thank you, Dr. Braka. So I'm going to ask the next question. This is from William from Bloomberg. Dr. Gilson, you can answer the question and Dr. Teube can complement. What is WHO's opinion on the idea of people in wealthier, heavily vaccinated countries receiving booster shots before people in Africa receive any of these doses? Dr. Gilson and Dr. Teube can complement.
OK, merci beaucoup pour la question. Ce qui se passe, c'est qu'il se pose deux problèmes majeurs. Il y a un problème d'éthique, et c'est sur cette question que coule un problème technique. Sur le plan épidémiologique, on n'a pas suffisamment de données pour déterminer le besoin de booster et le moment où il faut donner le booster. Alors, il y a un autre problème, c'est un problème d'éthique. Si les 11 pays les plus riches donnaient les boosters, ils auront besoin d'à peu près 800 millions de doses de vaccins. Alors que vous savez qu'en Afrique, on a effectivement besoin de ces 8 millions de doses pour atteindre au moins 30% de population d'ici la fin de l'année 2021. Et dans ce groupe est inclus les personnes les plus vulnérables, à savoir les personnes les plus âgées, les personnes avec comorbidité. Et c'est dans ce groupe qu'il y a le plus de décès. Or, l'objectif est de sauver des vies. Et l'objectif est d'assurer la continuité de service. Et l'objectif est d'assurer de rouvrir la société et l'économie. Donc, au lieu de mettre à la disposition des pays les plus riches les 800 millions de doses, nous conseillons de mettre à la disposition des pays africains ces 8 millions de doses pour vacciner au moins 30% de population pour sauver des vies et assurer la continuité des services et aussi contribuer à la réouverture de la société et de l'économie. Merci.
Merci beaucoup, Dr. Gilson. Dr. Terube, do you want to compliment, please?
Thank you very much, Mary. I just need to say, to remind people that yesterday the WHO Director General, Dr. Tedros Ghebreyesus, actually called for a halt to these booster shots by wealthier countries until the poorer countries vaccinate their priority populations. So that is the stand of WHO, a call to a halt to these booster doses.
Thank you, Dr. Terube. The next question is coming to Mrs. Joanna. How is Angola rolling out the different types of vaccines to ensure that there is no wastage?
Ok, mais uma vez bom dia. Nós adotamos a estratégia de todos vacinados primeiro serem cadastrados. Isso para as primeiras doses. Para as segundas doses, estas pessoas recebem uma mensagem e com esta mensagem eles vão aderindo os postos de alto rendimento, de vacinação. Nós conseguimos fazer esta gestão, porque os nossos postos de vacinação têm estruturas muito grandes, como se fosse um campo, com várias secções, várias áreas, onde nós podemos colocar 3 tipos de vacinas. E, no entanto, as pessoas, quando aderem ao nosso posto, ou vêm pré-cadastrados já a partir das suas instituições, ou fazem o pré-cadastramento no PVAR, e só assim têm o acesso. Então, para que isso aconteça, nós temos que garantir recursos humanos suficientes e também um controle rigoroso na logística, que nós temos que gerir no mesmo dia, em função da demanda. E até agora nós não tivemos problemas. Não sei se consegui satisfazer a vossa pergunta.
Obrigada, Mrs. Joanna. Then to you, Dr. Terube, can you answer this question? What might explain the governor of Lagos' observation that 40% of people vaccinated in Lagos failed to return for their second dose? Is it the issue of hesitancy or the reputation of AstraZeneca vaccine?
That's an important question because it is not uncommon that we have issues with loss to follow-up when it comes to vaccination. But for COVID-19 vaccine in particular, there's a difference between have failed to come back for their second dose or have not received their second dose. So why would people not have received their second dose? Because we had a lag. We know that we have had issues with these vaccine doses. So that could explain why we have had 40% of the people not yet received their second dose. Probably they've not, because for AstraZeneca, the schedule between the 2 doses is 8 to 12 weeks. So if the governor is counting anybody who got a first dose and is not registered as a second dose, we need to know, have they reached their 12-week mark for their second dose? And if not, if they have reached the 12-week mark, because that also reduces the number. But also we have issues such as communication. Indeed, hesitancy does come and exist in between, but we've not seen this as a major issue for all the information we have. For people who have received their first dose, we have not had hesitancy as an issue for them to come back for their second dose. There are usually many reasons why people would not come back for a second dose. Was there a change in vaccination sites? Was there a change in number of in availability of vaccine and access? So which was very common with the COVID-19 vaccine. So there's a lot that needs to be investigated. We've not had the issue of hesitancy from people who have had their first dose. We've not had it documented anywhere. And also issues with AstraZeneca, these were cleared, and now we no longer have populations having issues with AstraZeneca as a brand in particular.
Thank you, Dr. Fiona. Dr. Bracker, this question is coming to you. Can you provide an assessment of the impact of it on this pandemic? Also in Senegal, as in other several African countries, observation on the ground seem to point that there is a serious discrepancy between the reported cases and deaths and then the actual situation on ground. Can you also update on how wide you think this gap may be? With the latest surge on the continent, has the gap gotten worse? Did you identify new reasons for this discrepancy? This question is coming from Lauren from Agence France. Dr. Bracker, please.
Thank you for that question. Indeed, we have seen an increase in the number of new cases in Northern Africa and West Africa, and more so a stabilization in Southern Africa, in Central and Eastern Africa. And we do know that the recent Eid festivities, yes, they were mass gatherings and social interactions. And it is likely that these could also have fueled the increase in the number of cases that we have seen in Western Africa and parts of Northern Africa, because we do have a large Muslim community there. In addition to the other factors, as mentioned, around the increasing transmission of the Delta variant. To the question on the discrepancies in the numbers of cases that are reported in Senegal and several other countries, we recognize that with the current testing strategy, we are not able to do mass testing for everybody. And so infections that are mild or asymptomatic may go undetected. So the numbers that we see are an underestimate of the actual burden. And so we do know that we are not able to test everybody. And so what we have is based on the numbers that we have been able to test. And we know that that's not a true reflection. So we recognize that. And as we look at these numbers across the countries, we do know that there is need to ensure that as much as possible that we prevent spread of the virus using the measures that we know of, because it's likely that the asymptomatic cases could be out there that we do not know of.
Thank you, Dr. Bracker. And to you, Dr. Fiona. Please, can you answer this question from Matthias from Germany? do you know if and where COVID vaccine productions are planned for in Africa? Wouldn't it be helpful to have facilities in Africa that will produce for the continent?
Indeed, it would be a dream for Africa to have vaccine manufacturing on the continent. So far, we've had a number of countries that have signed deals for the fill and finish. We had Senegal as one of the first countries in the region that has been producing the yellow fever vaccine at the Institut Pasteur. And recently, Senegal signed a deal at Still Institut Pasteur with Universals to manufacture the COVID-19, still again for the finish and fill for the COVID-19 vaccine starting mid-2022. We know that South Africa is already doing the fill and finish for the Johnson & Johnson, which is such a big thing for us. And these vaccines that will be finished and filled in South Africa will be used only in Africa. So that shows you that we have started and we have the capability for this. And South Africa is also starting a knowledge transfer hub to help increase this manufacture. Egypt is also having some of the aspects of the vaccine manufacturing and has mentioned that they will release their first 1 million doses of Sinovac. This is one of the China vaccines in the coming few months for their population to use. Actually, I think they should have started even in August. So we also do have Morocco, which is a country that is also going to do the finish and fill. So there is capacity on the continent. What we need now is actually technological transfer. We are able to manufacture the vaccines, but not from scratch. We need more technology transfer, and the wave of the TRIPS that was given, and we're able to do that. So we have Senegal, we have South Africa, Morocco, and Egypt that have this capability.
Thank you, Dr. Fiona. Lisa from VOA, do you want to ask your question live? Lisa, are you there? Okay, let me read out her question. Vaccines have expired in some countries and become useless because of vaccine hesitancy and other reasons. What strategies do you have to prevent this happening? Dr. Gilson, please.
Merci beaucoup pour cette question. Actuellement, la stratégie que nous proposons au pays, c'est d'abord d'organiser ce qu'on appelle des revues intra-action. Au cours de ces revues, tous les experts du pays, à tous les niveaux, national, régional, même au niveau local et même dans la communauté, c'est pour identifier effectivement les raisons du fait de n'avoir pas suffisamment utilisé ces vaccins. Donc, les raisons de cette hésitation dans la communauté ensemble et de trouver des stratégies correctives ensemble. Et dès que les stratégies correctives seront trouvées, ils vont mettre à jour le plan de vaccination et de déploiement de vaccins pour montrer comment ils vont surmonter ces hésitations pour les phases qui sont en train de venir. Donc, toutes ces actions correctrices pour éviter, pour augmenter l'utilisation, la demande de ces vaccins vont être mis en place. L'autre chose que fait l'OMS, parce qu'une autre raison qui est à la base de ça, c'était l'insuffisance de fonds pour les coûts opérationnels. C'est de faire les plaidoyers pour que le fonds pour les coûts opérationnels pour toutes les composantes, y compris la composante communication et donc la lutte contre les hésitations, soit mise à la disposition de pays afin d'appuyer la mise en œuvre de ces actions correctrices qui auront été définies lors de ces réunions, de ces revues interactions et qui vont faire partie des activités correctrices dans le plan de développement, de déploiement de vaccination pour la prochaine phase. Donc voilà en résumé, d'abord rechercher les raisons, et les raisons sont spécifiques pour chacun des pays, déterminer les actions correctrices et mettre à la disposition les ressources pour mettre en œuvre ces actions correctrices afin d'augmenter la demande de ce vaccin. À vous.
Thank you, Dr. Gilson. And the next question is coming to Mrs. Joanna. There is a lot of misinformation about COVID-19 vaccination. How is Angola dealing with this misinformation, and how are you engaging the communities to make sure that everyone is vaccinated? Mrs. Joanna, please.
Obrigada. Em princípio, quando da recepção das primeiras vacinas, que foi da AstraZeneca, de facto, houve rumores. E esses rumores foram passando através do sistema como posso dizer, das redes sociais, não é? Mas nós sabemos que quando há o surgimento de uma nova vacina, mesmo a de rotina, não é? Que é aquela que habitualmente nós damos no calendário nacional, quando há surgimento de uma nova vacina, nós temos que contar com rumores que poderão vir das comunidades. Mas nós temos uma grande capacidade em fazer campanhas de comunicação através dos mídias, encontro com as comunidades, envolvendo todos, por exemplo, líderes tradicionais, todas as pessoas influentes da comunidade, de algumas instituições. E conseguimos ultrapassar toda esta situação. É para ver que, quando se fala de alguns países que não conseguiram vacinar, porque as vacinas expiraram, a nossa demanda foi tanta, a procura é tanta, e chegamos a um período que não tínhamos mais vacinas para podermos cobrir a procura, não é? A demanda de pessoas que vinham. Então, é para ver que nós conseguimos ultrapassar esses rumores. Foi feito um grande trabalho de mobilização, não é? A vacinação, a partir mesmo do presidente, ministros vinham ao público para falar das vantagens da vacina, e com isso as pessoas tiveram grande credibilidade, principalmente quando o presidente da República recebeu a vacina. Aí é que todo mundo correu para o posto de vacinação de alto rendimento, que nós chamamos de PVAR. Toda a população queria ser vacinada, não só com a Sputnik, que foi feita pelo presidente, mas com todas as outras que nós tínhamos disponíveis. Só que, infelizmente, não podíamos cobrir, porque nós temos definido um grupo prioritário, que eu já fiz aqui referência, que são os trabalhadores ou profissionais de saúde da linha da frente, e aí consideramos os que estão, por exemplo, nas zonas de quarentena, os que estão na zona de tratamento do Covid, os órgãos de defesa e segurança, proteger pessoas com comorbidades, e então nós tivemos que algumas restrições para outras pessoas que não teriam acesso. O nosso problema é a insuficiência da vacina. É o que nos preocupa, porque se tivéssemos vacina até agora, é só para vocês verem que nós temos idosos que não foram ainda cobertos, porque temos escassez de vacina, e que percorrem mais de 40 quilômetros para alcançar o posto mais próximo para a vacinação e não encontrar. Isso é triste. Por isso, o nosso apelo é mesmo ver se resolve a situação da África, como já ouvi aqui falar no painel, e de Angola, em especial. Obrigado.
Thank you very much, Mrs. Joanna. Dr. Fiona, please, can you weigh in on this question? How is the regional office tackling the issue of misinformation across the region?
Thank you indeed, Mary. Because of this vaccine, like Ms. Admiro mentioned, coming with a lot of hesitancy, not just this vaccine, but COVID vaccine in particular has been special in a way. So WHO anticipated this, and we put out a whole infodemic response team, which is called the Africa Infodemic Response Alliance, which is a consortium of several partners that come together, and we do media hearing, listen to all the infodemic out there, all the questions that people have, and come up with answers to these questions. We've put up a whole site on viral facts, and we ensure that this information is answering the questions and the misinformation that is out there in the public. So we have the Africa Infodemic Response Alliance, we have the viral facts, and we do these press briefings just for that reason, also to counter misinformation also, and to provide the right information to the media and to journalists that are the people who have the credit, who are part of the credible source of information. We do media training also for spokespersons in countries, for opinion leaders. We have done a lot of things that we do in the background to ensure that we put out the right information in the easiest way possible for community members to understand.
Thank you, Dr. Fiona. Indeed, misinformation is a challenge against this COVID-19 fight. I'm going to pose the next question to you. Again, this is a question from Rhoda from BBC. With COVAX now relying on vaccine donations from rich countries, and these vaccines have a short shelf life, will the WHO give a time period of how many weeks left to the expiry date for countries to donate their vaccines? For example, Kenya says it only accepts vaccines with minimum 8 weeks before expiry. Dr. Fiona and Dr. Gilson can complement if there is addition.
One thing I need to mention is that there is a lot that happens behind the scenes before these doses get into countries. So indeed, one of the agreements we have had with countries, and one of the issues we have brought to the table with countries that are donating doses, is the issue of expiry, that the time between the vaccines arriving in countries and the time that they will expire, which we call the shelf life. So we have asked indeed that we have not less than 2 months expiry, but also before we receive these donations, we ensure that the allocation does not come randomly. We go through a whole allocation process as COVAX. The partners sit down and agree on which country we think is able to utilize, for example, the short shelf life vaccines, given the previous absorption capacity and rate of utilization of the vaccines they've received. And also we have had agreements, for example, with Johnson & Johnson, with the manufacturer in the US FDA, between COVAX and the US, to ensure that the doses that are coming to Africa are having all through the COVAX facility. The Johnson & Johnson doses have a longer shelf life than the doses, for example, they're using in the US. This is the same with the doses that are coming through the African Union. We do those negotiations and those technical discussions with the manufacturers and donor countries. And indeed, much as COVAX is relying on donations, is not solely relying on donations. We are having new advanced purchase agreements with several manufacturers, and COVAX shipments and procurement doses outside the donations are also coming in. Indeed, we do have these discussions before then. UNICEF, who does the movement of these doses, is also on the table to have these discussions. They made it very clear that they are able to move doses from, for example, one country to another when they have at least 6 weeks of expiry. So all that is put into context, and we ensure that the country that will receive any particular dose, any particular shipment, is able to use these vaccines before their time of expiry. And as Dr. Paluku mentioned, we have prepared the countries so that as soon as the vaccines arrive, they are able to roll them out.
Okay, thank you, Dr. Fiona. Dr. Gilson, I'll add a question, and then if you have something to complement on the questions just answered, you can answer together. A recent AU survey of 15 African countries shows that skepticism about the COVID vaccine remains high in many countries. If some African countries don't achieve their immunization targets, will COVID-19 become endemic in those countries? What consequence would this have for the real continent and the world at large? This question is from Christine from Dutch Press. Dr. Gilson, please.
Merci beaucoup pour cette question. Hein. Si la demande n'augmente pas, ce qui est sûr, la maladie va se transmettre très vite. Et ce qui va arriver, c'est qu'on va avoir beaucoup de décès, d'hospitalisation et de décès. Et ça, ce n'est pas une bonne chose. Ça, c'est une première conséquence directe. La conséquence indirecte, si la consommation n'augmente pas, le fait que le virus va circuler longtemps, il va développer, on aura beaucoup de nouveaux variants, avec le risque que ces nouveaux variants échappent aux vaccins qui sont déjà sur le marché. Ce qui pourrait remettre en cause tout le travail qui a été fait par les autres pays, par les personnes vaccinées. Donc, la prise des vaccins est une responsabilité individuelle, communautaire et même mondiale. C'est pour ça que toutes les actions doivent être mises en œuvre pour pouvoir lutter contre toutes ces rumeurs, toutes ces informations inadéquates en défaveur de la vaccination, pour les surmonter afin de mobiliser la population pour qu'ils prennent les vaccins. Et s'ils prennent les vaccins, on va éviter les hospitalisations, on va sauver des vies et on va réduire la possibilité pour les vaccins de développer, pour les virus de développer de nouveaux variants. Et si on augmente la couverture, on pourrait contribuer à réouvrir nos sociétés et nos économies. Donc voilà de façon résumée les risques si la demande n'augmente pas. À vous.
Thank you, Dr. Gilson. The next question is to you, Dr. Braca. This question is coming from Lucas. Is there a lack of oxygen, or will there be lack of oxygen in the next few weeks in countries in Africa?
Thank you, Lucas. Oxygen is part of the recommended components of case management for severe or critically ill COVID-19 patients. And with the increase in the number of COVID-19 cases that we have seen with the resurgence in the third wave, we have seen that the demand for oxygen at the moment is estimated as 50% more than we needed at this time last year. So the demand has certainly gone up with the rise in cases. And the barriers really are around the availability of adequate numbers of oxygen cylinders, the functionality and maintenance of oxygen production plants, and the skills, the personnel skills to manage the use of oxygen or to manage the oxygen plants. So WHO has been working with the countries to scale up the availability of medical oxygen during this pandemic. And we have provided oxygen cylinders, supported countries in resurgence, such as Rwanda, Liberia, Uganda, to procure oxygen cylinders. We have also supported some countries to revive their oxygen plants, such as Kenya, South Sudan, and DRC. And we're also providing capacity building in countries to improve the facilities, improve the capacity to maintain the oxygen plants and also to administer. And we have seen marked improvement in terms of oxygen availability in the region. Looking back, we had 68 oxygen producing plants at the beginning of the pandemic in the region, and we now have over 100. And we've also seen marked increase in the number of oxygen concentrators and the availability of oxygen cylinders. However, we do know that this is an area that still remains a critical gap, the availability of oxygen cylinders and the accessories in order to meet the demand. So we still need to scale up the production and the availability of these items, especially as we are seeing a resurgence in a number of countries.
Thank you very much, Dr. Braka. And then to you, Dr. Fiona, this question is from Naftali from Chinua. He's also asking to shed light on vaccine hesitancy in Africa. Again, what is being done to minimize it, and which demographics, age, gender, geographical groups are worst affected by the vaccine hesitancy on the continent?
Thank you very much, Mary, and thank you, Naftali, for that question. So from the studies that have been done, generally we know and we have seen the biggest demographics that are the people who are having the highest hesitancy or who spread the hesitancy are people who use social media. And social media, especially, we've also seen that it is the literate people, the literate, the so-called the intellectuals. So someone has coined the people who coined the COVIDiot idea around that. So it is the people who are actually literate, people are able to read and pass on these videos and information that have been seen to have the highest level of hesitancy. But we have also seen that Central and West Africa had higher levels of hesitancy compared to East and Southern Africa. It is the middle-aged and youth that show higher levels of hesitancy. So there is people who spread the misinformation, but there are people who are the priority groups that we have. So we ended up having healthcare workers, a part of the healthcare workers that did not understand the vaccine show hesitancy at the beginning. But with the current third wave that hit Africa, we've seen hesitancy levels really, really drop, because people have understood that indeed this pandemic does exist, unlike the other last two waves, where people still did not believe that this disease is very difficult. But also when they saw the Western world vaccinate higher numbers and more or less return to normal life, we have seen the hesitancy reduce. So again, people who use social media, who are the middle-aged and educated people, are the ones that have been seen to have the highest levels of hesitancy.
Thank you, Dr. Fiona. And again to you, what is WHO's position on vaccine passports and EU digital green certificates? So this question would be best suited for Dr. Braka in the international health regulation area. But
WHO's position is that for now, we do not need these vaccine passports because of the difference in equity, in the inequities in access to these vaccines. Africa, for example, and other low-income countries have vaccinated really just a drop in the ocean of their populations, while the higher income countries have vaccinated. We have countries that have vaccinated up to 80% of their populations or even more. So we cannot compare these two situations, and WHO's position now is to at least for now to have a halt to these vaccine passports, not to be a requirement for travel. Countries can make those decisions, but they are not a requirement for travel right now. And we have also seen that the European Union countries that had put this green pass for freedom of movement within their countries and left out some vaccines have changed their status, and we now have free movement also accepted, and from other vaccine people who have used vaccines that were not listed under the vaccines that were allowed. But again, WHO's stand still remains very clear until we all have equitable supply and enough doses to cover the whole population globally.
Thank you, Dr. Fiona. Indeed, this is very good news for international travelers. Dr. Braka, do you want to weigh in on this?
Yes, just to buttress what has been said, the International Health Regulations Committee, they are sitting in April, did recommend that to state parties that we do not need to have this proof of vaccination as a requirement for entry into countries, especially in view of the growing evidence that we are still building up on the vaccines, but also the gross inequities in terms of availability of vaccines across the regions. And so based on that, WHO does also have a position paper on this. We do not recommend this as guided by the IHR committee. And we are encouraging that more effort should be made to try and scale up the availability of vaccines to protect especially the high-risk groups across the world, as opposed to restricting travel across regions because of use of certain types of vaccines.
Thank you, Dr. Braka. We are now coming to the end of this press briefing. Let's turn to our two panelists. I will start with Mrs. Joanna and then Dr. Fiona to give us your final words. 1 minute each, please.
Começando por mim, primeiro agradecer por fazer parte deste painel. Foi muito importante podermos transmitir a realidade que Angola vive, não é, nesta fase de vacinação, e esperar que façam tudo os que têm os produtores, não é, para fazer passar a mensagem aos países ricos, os produtores da vacina, que não esqueçam a África, que nós estamos à espera da vacina. Queremos cobrir toda a população, queremos vacinar, porque os números estão a aumentar. Obrigada.
Obrigada. And to you, Dr. Fiona.
Thank you again very much, Dr. Stephen, and to our listeners again, thank you for joining us. The third wave in Africa is real and it is raging, and we are seeing some of the countries even getting to their fourth wave. So we are not there yet. We are receiving much more vaccine doses in the coming few weeks and days, multiple products from multiple sources, limited quantities of each product. We need to ensure that we do the right community engagement and communication to ensure that we have these vaccines get into the arms of people. Yes, we shall get the doses. We have gotten the doses, but this is very different from getting these doses to the arms of the people who need them. So in order for us to prevent another catastrophe that we have seen from the previous waves, let's ensure that we spread the right information, people get vaccinated, but also ensure that we keep using the proven prevention measures of sanitizing or washing hands, social distancing, and ensuring that we are not part of the crowds and keeping in our homes and only move when we need to. Stay safe, and thanks again for joining us.
Thank you very much, Dr. Atehube. Thank you very much. And I'm sorry for coming back to you. There was a last burning question from Esther. If you could just take 1 minute to answer and then we round up. Is the increase in price of Pfizer and Moderna in the Western market going to affect Africa in any way? And will those donor countries donate those vaccines if they are expensive, or we are doomed to get donations of the cheap ones? 1 minute only.
Thank you very much. We need to note that, for example, the US government, the donated doses that we are receiving have already been purchased, some of them that are coming directly to countries. But on the other hand, we have, for example, the US government or the European Union governments that purchase their doses through the COVAX facility. The COVAX facility has negotiated prices, so it is much easier and cheaper for us to purchase through the COVAX facility, the procurement to go through the COVAX facility. So the donors have noted this and are going through the COVAX facility to ensure that we get the right prices. And no, we are not doomed because the doses have already been given to us, even with the prices, the price tags that they bear.
Excellent. Thank you very much. So I would like to use this opportunity to thank our panelists and to also Dr. Braka and Dr. Gilson for stepping up to answer questions. Thank you to all journalists for the good work you're doing in making sure that the general population gets the right information. We will bring the press briefing for today to an end and hope to see you next week. Thank you and have a nice day.
Thank you.